It's a really great privilege being here, and it's a great honor, and I hope I do this justice. I'm going to take you on a magical mystery tour for the next little while. It starts in the right hemisphere of the brain, which is the conceptual, qualitative part of the brain, crosses the corpus luteum over to the left side. You'll ask me how you'll know when you're there. You'll know soon enough. And I promise you the last slide of this presentation will take you right back home to the right hemisphere. I keep you in suspense, anticipating that. There's nothing magic about what influences health technology in our society. It's driven by the same pushes and pulls that operate in society and across the spectrum of consumerism. Eisenberg in Shoptimism portrays a bloodless coup from engaged citizens to self-indulgent consumers that occurred in the 50s. And in Overspent American, Why We Want What We Don't Need, Score notes that the heart of the problem is competitive competition. I'm starting at a very kind of macro level. We're going to get granular in a minute. But I think that this is a very important concept because it's what drives the uptake and diffusion of technologies in the absence of evidence. I'm a little bit of a techie, I have to admit. I put my cards on the table. I love technology, I love innovation, and I think that drives our civilization. It's what defines who we are. The quest for knowledge, the quest for innovation, really does define what and who we are. So I'm going to draw at the beginning on two very popular futurologists, sociologists, who go back 30 years. If you want to know how good a futurologist is, or sociologist, read them what they wrote 30 years ago, and then fast forward 30 years later, see if they got it right. And the two I'm going to choose are Jeremy Rifkin, who wrote a book called Entropy. And in this, he argued that the unbridled acceleration of technology would eventually lead us back to the horse and buggy era through an entropic implosion. He cites the second law of thermodynamics, that energy cannot be created or destroyed, and we're going to go backwards. As we go forwards, we're going to increasingly increase the risk of going backwards. And then, of course, Alvin Toffler argued, the great optimist, that technology can only improve our lives, and we're going to end up in nirvana as technology improves. These opposite perspectives are as relevant today as they were as we grapple with environmental issues, depleted energy reserves, despite rapid advances in technology, which promises a perfect life for all. So I don't think we've resolved the issue yet. I think we still have that balance in our approach to technology. The consumer revolution does affect the public's perception of the uptake, diffusion, and access to technology, and gets people very upset when the health system denies access to them. Those involved in the promotion and adoption of health technologies must intuitively or deductively play into the global consumer marketplace. Decisions, we're probably at the corpus callosum right now. Decisions, moving over the left hemisphere, decisions may occur in the health system at a macro, meso, micro level. The macro level is at the health systems level, where policy is generated at a macro level. The meso is the institutional level, and the micro is the provider-patient interface. I would argue that you need an alignment between the micro, meso, and macro levels in order to produce a consistent, patient-centered, and accountable healthcare delivery system. And to succeed, the evidence-based process must be inclusive and transparent and requires honest and trusting interactions across the entire continuum of micro, meso to macro. And we don't really have that in Staples at the moment, in any health system that I'm aware of. So at the micro level, the selection of treatment intervention is a deal made between the physician and the patient usually. From the physician's perspective, this may be influenced by an individualized assessment of the patient presentation, by past experience, intrinsic biases, and current knowledge. The patient's perspective is driven by, amongst other things, cultural aspects and balancing risks and benefits from their individual perspectives. The meso level, institutional level, decisions about uptake of health technology depend on affordability, on effectiveness, but there are other things at play as well. The institutional profile and keeping up with other institutions. So there is a huge demand now for the role of evidence in trying to filter out some of these issues. So what is evidence? I was stunned actually. I looked up evidence, I Googled it just for fun, and this is about 2 years ago. Whoops. Marco Peretta, better known as Evidence, is an American hip-hop artist, producer, and member of the rap group Dilated Pupils. I understand Dilated Pupils, I'm not sure about Dilated Pupils. That's new to me. It's also a science fiction story which is written by Isaac Asimov. I would define evidence as the assembly and presentation of facts weighed against the scientifically validated hierarchy that allows the quality of the evidence to be described and compared. And this is health technology assessment. So let's examine some of the pressures on our health system that are being driven by health technologies and are creating renewed interest in using evidence as the basis for making choices. With some humility, I have to say that what is developing in Ontario through the Ontario Health Technology Advisory Committee, Frank's a member of that, and he's in the audience, or OTAC, and the dyad with the Medical Advisory Secretariat, as the evidence recall, has created a lot of international attention. I'm not going to lose that right now, but it's an interesting dyad, an interesting concept which I will be presenting. So the sustainability of health systems is being threatened globally. Being part of the ministry, I've got to put the slide up, due diligence. Spending on health in Ontario is growing at 6% per year and has reached $45 billion annually, having grown 45% over the last 7 years. That's huge. In the context of this presentation, it's estimated that after adjusting for inflation, 66% of the increase in health costs are attributed to new interventions which are driven by health technology. And there's no indication that this is going to let up. Health Canada estimates the 60,000 non-drug technologies in play in our health system at the moment in Canada, and they review 4,000 new health technologies annually, which is the same as drugs. I don't do drugs, by the way, I only do non-drug technologies. So, the emphasis is going to be on non-drugs. There's also a quiet revolution occurring for non-drug technologies that is worth discussing. First of all, there are increasing examples of non-drug technologies taking over from drug technologies, or being used in as adjunctive treatments with drug technologies. I eat, sleep, this stuff over the last 8 years, and it's really interesting to see what's really playing out. Going from pill popping to bionic man, is this true? Well, here's some examples of some conditions which are gradually being taken over by non-drug technologies. Ventricular arrhythmias, which can be lethal, used to be treated with drugs such as amiodarone. Now we have implantable cardiac defibrillators. Atrial fibrillation, a chronic condition, treated with drugs. Increasingly, there are certain patients who are candidates to have the offending, or the nerves from the pulmonary vein to the atrium severed endovascularly. In a cath lab, it takes, I think, 4 hours, and the condition's gone. Obesity, we now have bariatric surgery. Depression, the happy center, you'll be pleased to know, was identified in Toronto by Toronto researchers. It's a little area, one cubic centimeter in the brain. We now have neurosurgeons at Toronto Western who are stimulating the happy center, and they have initial preliminary results that 55% of people who are severely depressed and drug resistant are cured using deep brain stimulation of the center. Let me just give you some information on bariatric surgery, which is really exploding on us. It's expanding exponentially at the moment. So this is the mean percentage weight change in the Swedish obesity study published in 2007. And the top, you can see from, these are patients not treated with bariatric surgery in the study that chose not to have bariatric surgery. These patients had banding, a little band slipped over the proximal part of the stomach, and there's a sustained weight loss of approximately 16% out at 15 years. And these are patients who had bypass surgery, and there's a sustained weight loss of 26% at 15 years. Well, that's great, because these patients are losing weight, but it actually gets a little bit better. Because the comorbidities associated with obesity have also been impacted by this treatment. And this shows that the incidence of diabetes for those people that had the procedure has decreased at 10 years with an odds ratio of 0.25. The incidence of hypertension at 2 years, the incidence went down, was almost statistically significant. It's not significant at 10 years. But this is the interesting one. Recovery. This is cure. Recovery from diabetes in this population. 25% of people with diabetes are morbidly obese. Odds ratio of 8.42 at 2 years, but going down to 3.45 at 10 years. And that is truly remarkable stuff. And recovery from hypertension is still significant at 10 years in this population. This is the exponential increase in bariatric surgery for people in Ontario. I'm not going to dwell on that. And this is the increase in endocardial ablation for the treatment of atrial fibrillation in Ontario. Both of those graphs, the bariatric surgery and this one, I like to believe were influenced by OTAC recommendations, which preceded the diffusion of these technologies, and gave rise to funding decisions made by the Ministry of Health. So why have I chosen those two? I've chosen them because we now have non-drug technologies that are given upfront before any other treatment intervention that are curing disease, but we have to pay upfront for the technology. We become mortgage junkies in healthcare. We become accustomed to amortizing our costs of healthcare over a 20-year period of the chronic disease for obvious reasons. And along come two technologies, these two in particular, which cost a lot of money to fund in the upfront part of the life cycle. And I'm not sure how affordable it is and could be compounding the effects of the incremental costs associated with health technologies. The other thing that's happening is the rapid replacement of old technologies with new technologies. Now, a lot of the industry complains that the market exclusivity for a new non-drug technology in Canada or in North America is 1 year. And that is because of patent laws, or there are different things playing into this. But if you only have market exclusivity for 1 year, don't be surprised that the cost of your product is going to be quite high to recover your developmental costs and profit margins. But anyway, stress urinary incontinence turns out to be a huge problem amongst women in Ontario. We actually conducted a poll of about 1,300 women, and we know exactly what the prevalence and the acuity of this condition is. Used to be treated by cold suspension, which is an invasive procedure, can now be done almost as an outpatient procedure using mid-urethral slings at half the cost of cold suspension. Brain aneurysms, treated by craniotomy and clipping aneurysms. You can now float platinum coils up the femoral artery into the brain, occlude the aneurysmal sac and stop the bleeding without doing a craniotomy. Coronary artery disease, visualizing the coronary arteries, standard way of doing that is coronary angiography, and now 64-slice CT angiography is kind of elbowing its way into that. And so it goes on. I can't go through all of these because time doesn't permit, but I think it makes the point that these technologies are changing so rapidly it almost makes your head spin. This is a mid-urethral sling. Diffusion, again following an OTAC recommendation. Whether that recommendation was the cause-effect relationship, we'll never know, but the temporal relationship is interesting. And here we can see in the green curve the total number of women who are now receiving treatment for this condition. In red, the volumes of mid-urethral slings, and in blue, the volumes of the more invasive corpus suspension, which is going down. That's exactly what we want to happen. This is artificial disc replacement for degenerative disease, the lumbar discs. Again, volumes are going up. It's a better procedure, and that's entirely appropriate. This is a negative one, in case anyone asks a question later on. Here's an OTAC recommendation that you should not be doing arthroscopic lavage and debridement for osteoarthritis of the knee. There's the OTAC recommendation, and this procedure in Ontario is rapidly leaving the radar screen. The most important technology here, the slam dunk technology, is total knee replacement. Now we have other pressures that are now kind of, making this a very urgent cause for attention in terms of the adoption of technologies. This is a study published by the RAND Corporation in 2006. On the x-axis, going from right to left, barriers to the uptake of technology. So that's the least barrier, that's the most, going up to 100. And up here is the capacity for the uptake of technologies. They used a panel of, I think there were 17, 5 of which were health related. And you can see where Canada sits. It's very nice because it shows that we have a very kind of sophisticated society, and we're going to be major adopters, according to RAND, by 2020 of technologies in general. But for us in the health system, it becomes even more imperative to put an evidentiary filter in place that allows us to decide which technologies are going to be adopted in the system, given the fact that we have a fiscal constraint and an increasing demand imposed by these technologies. Our health system is very complex, and the complexity of our health system actually makes it easy to diffuse technologies. So here's a health system with 21,000 physicians, 139,000 nurses, 154 hospital corporations. Industry loves this. They've told me they look for the weakest link in the system. And they diffuse their technology through the weakest link, and then they know the domino effect is going to operate. There's going to be inter-institutional rivalry, and then physicians and patients are going to demand equal access, and they know that their product can diffuse very rapidly. And I put this up just to show you the kind of pressures that we're under in terms of the uptake and diffusion, and why we need an alternative way of dealing with this problem. And before I get into evidence, decision making is more than about evidence. And this is taken from OTAC, and this is their decision determinants. And I'm just going to take you down the left side of the slide, that the decision needs to be based on clinical benefit, the evidence of effectiveness and consistency with societal and ethical values. And we are bad at this. I mean, if you look at the literature on ethical and societal values in technology, the cupboard is bare. There's very little there. And we know Mita Giacomini at McMaster, we've given her some funding to try and help us incorporate that into our analysis. And I think they're working pretty hard on that right now. Value for money, cost effectiveness, and feasibility of adoption. All these play out in the decision of whether you're going to adopt a technology or not. I want to take you through the life cycle of the diffusion curve for technology, because this, I think, reflects where the pressures are, where the opportunities are in the technology. So let's take the first phase, research and development. Research and development is usually undertaken by industry, sometimes and increasingly academia feeding into that equation. I'm going to just call it research and development. And this is where the pipeline begins. There's an incubator, then there's a pipeline, and then if it makes it, it goes to regulation, and then it diffuses. there's some wonderful opportunities in the R&D part of the life cycle of technology that we're missing. We're missing it in chunks. Because when you think about it, health systems have become passive adopters of technology. Whatever comes through the R&D phase, the first phase of the life cycle of technology, is basically given to health systems to implement. There's something wrong with that equation. And if we looked at this as a corporation, no corporation of $45 billion would accept that. You would want to have some influence over what's coming down the pipe. You want to have some influence over the R&D, and you want to have some relevance over what's being produced in the R&D part of the cycle. So the opportunities for health systems to move further upstream, which is the R&D part of the cycle. And I'll take it a step further, and this does not necessarily represent government's perspective. I'm still employed for having said this on numerous occasions. I honestly believe that industry is part of the health system. It's our R&D of the health system. You can't run a $45 billion enterprise without research and development. And the relevance of R&D to what we do in our health system is significantly impacted. And it should be a two-way flow, not a unidirectional kind of commitment to taking up whatever, in a passive way, whatever industry puts in our lap. Sometimes they get it right. Sometimes you have a relevant technology that should be diffused. But sometimes they get it wrong. And then you have to shoehorn your technology into the health system. And of course, at the inflection point, which is the second faucet shown here, is where you get into evidence-based analysis, where you can define the shape of the curve. It's the only way in which you can actually shape the curve of diffusion, and hence the cost curve, is through the evidentiary portal. And it's at the inflection point that Massey and OTAC operates. And it's at the inflection point that you can put the parameters around the diffusion. You can either open that faucet up, go full throttle, or you have to turn it down a bit because there are certain restrictions to the diffusion. And that is what I'd call the evidence-based analysis effect in shaping the cost curve, shaping the diffusion curve for the technology. You'll see that at the inflection point you can make one of four decisions. You can have an unconditional yes, you can have an unconditional no, you can define relative obsolescence, or there can be uncertainty, where you have an interesting technology but the level of evidence doesn't allow you to make a decision. And that is where the notion of field evaluation studies was born in Ontario. I'm going to talk about that in a second. So what have we put together that is kind of that people are interested in? This grew, I wish I could say we sat down and we drew blocks, little squares, and we said this is where it's going to work. This is an organic evolutionary process. But it looks neat now anyway. But we have the Ministry of Health and Ontario Health System make application to OTAC to review technology. OTAC then prioritizes those recommendations, passes it to the Medical Advisory Secretariat, and that is where the evidentiary core begins. What is unique about this process? There's been an incredible partnership here between what happens in the Medical Advisory Secretariat and academia. We have looked to academia to bring us the relevance and the brilliance of what academia has to offer, and made it relevant to the health system's needs. So here we have two examples of the program for the assessment of technologies in health that we funded at McMaster, and at the Toronto Health Economic and Technology Assessment Collaboration out of the University of Toronto. And they do the economic analysis. They work with us in the systematic review as well. We engage expert panels and experts in industry in the process. And this takes 16 weeks. The average in any other HTA agency is about 18 months. I don't know why it's 16 weeks. We've been reviewed by international reviewers. They seem happy with the product. It goes back to OTAC. OTAC then makes a recommendation to the Health System Ministry of Health. If there's uncertainty around whether they should approve or make a recommendation for the adoption of a technology, it goes back for a field evaluation study where we can evaluate the technology in real time in the Ontario context. Why is that important? Why don't we just say, heck, we'll wait for the researchers in other parts of the world to produce the evidence? Because that would invite a passive diffusion of the technology in the health system, and then it's too late to put it back anyway. So these field evaluation studies are really conducted by PATH, by Theta. ISIS gets involved. We use a usability lab at UHN. We get into knowledge transfer with our products, and the implementation, increasingly now through the physician schedule of benefits, where the OMA has now come in and are increasingly looking to OTAC recommendations to guide the new fee codes and the LINs, and that's the micro level, the meso level. The LINs are involved, the hospitals are involved in trying to lay the infrastructure for those health technologies. So the three planets are now aligning between the macro, the meso, and the micro in Ontario, and I think that augurs well. We're also able to track OTAC recommendations, the uptake of the technologies, and report that back into the process. And we can do that by LIN, which is naming and shaming in the annual report of OTAC. Through this collaboration, you can see that the whole health system has now become engaged in the process. I can't go through this in any detail, but the dyad of OTAC and MASS is a very viable, very close kind of dyad. And then the research partners, which really excite me enormously, bringing in universities, academic health science centers, and the like. And I really can't go into any detail on that, but I think it's the complexity, that's just to make you seasick. But the complexity and the way this has grown in an organic fashion, I think augurs well for the future of this enterprise. So initially, we were looking at single technologies. I'm going to go through each one. No, I won't do that. But we were looking at single technologies, but it shows you how busy we've been. And of those single technologies, I've gone through this, and I've had our fiscal people in the Ministry of Health go through this as well. We've had 85% translation from evidence into policy or funding for these technologies, and there's something like 90 or 100 up there. Now, you'll see that as the years go by, we're doing less and less. Isn't that smart? We're getting bigger and bigger, we're doing less and less. We didn't like that job. And the reason will become more obvious in a minute. It will become more obvious now. When I used to sit around the senior management table of the ministry and say, hey, here's the implantable cardiac defibrillator, and here's another device, the kind of glazed look. You know when you're sitting in a meeting and suddenly the glazed look, what are you talking about? And it dawned on me that single technologies don't excite people at the macro or even at the meso level. What excites people is when you start to look at the more complex issues. Give me a disease condition. Show me the technologies that dominate in that disease condition, such as diabetes. So we began to look at the whole notion of what we call mega-analysis. And here's some examples of mega-analysis that we have got involved in since 2008. I have to say this is having a huge impact at a health policy level. So instead of looking at, the first one was hyaluronic acid injected into the knee for osteoarthritis, we said, why are we looking at that in isolation? Why don't we look at arthroscopic lavage and debridement and intra-articular steroids? Why don't we look at everything? And we disaggregated the technologies around that disease condition. Then we re-aggregated based on economic analysis and based on the quality of evidence. And we found that none of them actually worked. And then we started to get kind of bolshy, and we said, well, aging in the community, I'm going to show you that now. Colon cancer screening, 5 technologies. Which one of them dominates? Why should we use 5? Are all of them applicable? Diabetes, intermediate care, specialized care within the community, wound care prevention, cardiac diagnostic test just completed and just posted on our website for public and professional engagement. These are complex analyses. Do you have to have stress echocardiography versus SPECT versus CT angiography versus echocardiography with contrast. Which one of those dominates? Which one of those are most cost effective? How do we select? How do we know which one of these we're going to chase? And the same thing, we've developed these robust economic models that allows us to look at the downstream effects of technologies over any time horizon up to 40 years for diabetes at least. And we're now using those in what we do. See, here's a mega-analysis on aging in the community. And government, bless it, in wanting to do something around aging in the community, gave $700 million to LINS and said, fix aging. We don't like aging, fix aging. And that's the way government works, you know, and it's done with all the best intentions in the world. It's true leadership. It's trying to stimulate something that goes on in the community. We thought we could do something a little bit better than that. And we developed this transition looking at what drives people from being well in the community, elderly people, to being unwell in the community, to being admitted to long-term care home. 4 main drivers: repeat falls, incontinence, dementia, and social isolation. We disaggregated each one of those into individual technologies that played out for each one of those drivers. And then we re-aggregated based on evidence. And we found there's one overarching technology. These were mostly randomized controlled trials. One overriding so-called technology that dominated all 4 of those. Any guesses? Exercise. Randomized controlled trials. Honestly, moderate to high quality evidence dominates all of that. And then we also found 6 other technologies that played out for each one of those drivers. It got better for diabetes. We used the diabetes economic model, having done a systematic review, and we examined the diabetes strategy, and we found, using the model, the components of the strategy were to use multidisciplinary programs, insulin pumps for type 2, behavior interventions, and bariatric surgery. And the model showed us, the economic model showed us the cost effectiveness for multidisciplinary programs. That's an RN, a nurse, a dietitian, and a physician, was about $20,000 per quality. The threshold for acceptance for drugs about $60,000 per quality. Bariatric surgery was even more cost effective. It was $16,000. These are highly cost effective strategies. Behavior interventions was a little bit higher, but that can be coupled with the multidisciplinary programs anyway. And the insulin infusion pumps, which the government was really considering funding for type 2 diabetes, $1.9 million per quality. It's way above $60,000 for those who can't count. And then it goes even further. The model tells you that if you put the multidisciplinary programs in place, you're going to avoid 40,000 myocardial infarctions, 8,000 heart failures, 14,000 strokes, 13,000 amputations, etc. And it does that for each one of those. Now, how neat is that in telling us where we should be putting our money? So this is part of Mega-analysis. This is the diabetes story. It's on our website. Everything we do, by the way, is totally transparent. It's on the website, so you can knock it to pieces and do anything you want with it. You can even, you can peel it. But those are, so that is Mega-analysis. And finally, the other major contribution that has been made in Ontario right now is in the area of field evaluation studies. And this is a huge story. This is really, I didn't realize how big it was, because we were doing this in all innocence, to be honest with you. In all innocence, we started to evaluate technology, starting, I think it was with drug-eluting stents in 2003. And in our innocence, we said, well, let's just evaluate it. So let's just look at drug-eluting stents, which is the top one. You probably can't see it, but it's a story that tells the story of what's unfolding in Ontario at the moment through this initiative, and how it's embracing academic health science centers and universities and the whole health system. So let me go back. May 2002, cardiologists tell us there's a new stent coming. The stent is to open a blocked coronary artery. A new stent called a drug-eluting stent. Costs $1,200 more for each stent, but it's wonderful. We hear picking it up at all our conferences, etc. We did a great literature search, and they were absolutely bang on. This promised the world. The re-blockage or restenosis rates that were then published in September 2002 promised that for low-risk patients, the restenosis rate using the standard stent, the Evidencebased stent, was 23% in the randomized controlled trials, and for the drug-eluting stent, for 7%, gone down from 23 to 7%. Therefore, you have to use it. And they started adopting that technology very quickly in the United States. We had a different strategy. We said, here's $12 million to the cardiologist, just use whatever you want. Use a drug-eluting stent, a bare metal stent, whatever, but we insist we want to track each patient on a registry, including patient outcomes. Over the next 18 months, we tracked 21,000 patients in Ontario. We then did what's called propensity scoring. We were able to match two groups of people, those who got the bare metal stent, those who got the drug-eluting stent, and there were, I think, 3,200 in each group. And we found that for the low-risk patients, we had published in the New England Journal in September, they were right. The restenosis rate for drug-eluting stents in Ontario was 7%, bang on. The restenosis rates for the bare metal stent, the standard stent, was 7%. Now, the beautiful thing about this is that the study is run by the leading cardiologists in the province, theirs. It's their data, it's their information. We didn't have to convince them of anything. The conversion rate in Ontario from bare metal stent to drug-eluting stent is 30%, and it's holding at about 30% at the moment. In the United States, it is 95%. The cost effectiveness of a drug-eluting stent in a low-risk patient is close to $2 million per quality. I told you before, the threshold for effectiveness, $60,000. The drug-eluting stent, the best cost-effective strategy is actually for the high-risk patients, for which we're funding it in Ontario at the moment, and that's $220,000 per quality. But we weren't going to argue, because you know, there was a difference, and we just sort of said, we'll pay for it. And that was it. Now, we have completed 20 field evaluation studies in Ontario. The world experience up to 3 years ago was 4 clinical trials that have been funded by government or by third-party insurers to inform a policy decision. We have completed 20, we've got 16 more in the pipeline. And there are people knocking on the door and saying, how are you doing this? And we'd like to partner, etc. So it's a real success story. And I think it speaks volumes to the kind of health system and the academic sort of infrastructure we have in place and the way people think in this province. It's a truly remarkable story. The other example I will give you before I end is PET scanning. I used to stand up in trepidation when I used to talk about PET scanning, because me and some of my colleagues really got it on the chin, and us less than ministers of health in the legislature and others. And we decided when PET scanning first came to Ontario that instead of just opening the floodgates on PET scanning, we would put an evaluation process in place, because there was no evidence on clinical utility apart from one form of lung cancer. We have the largest evaluation program for PET scanning in the world. The studies have been published in the Journal of Clinical Oncology, Annals of Internal Medicine. The drug-eluting study, by the way, is published in the New England Journal of Medicine. And a lot of these studies are finding their way into good peer-reviewed journals. And we recently, and I think this is the real hallmark, this is the real watershed for us, that Cabinet actually looked at the results of the PET studies and have made a decision to ensure certain PET examinations or based on the evidence. Based on the evidence out of the evaluation program. And they wouldn't go beyond that. So I think that's the real telltale sign that there is a convergence here between evidence and true policy decision making at all levels. So I promised I'd bring you back. I think, you know, the bisection between this kind of intuitive decision making and evidence, I think, is being resolved in the province to a greater extent than any other health system I'm aware of. I speak in many, many different jurisdictions, and I still believe we have an incredible lead in this province. So I want to end this presentation with my favorite author, who clearly saw this coming in the late 1800s, and also brings us back to the unresolved, polarized perspective of Rifkin and Toffler in their prognosis on the future of technology. And here it is, Charles Dickens' Tale of Two Cities, and you all know this well. It's really worth reading, given the confusion and the havoc that's out there. It was the best of times, it was the worst of times. It was the age of wisdom, age of foolishness. It was the epic of belief. It was the epic of incredulity. It was a season of light, it was a season of darkness, it was the spring of hope, the winter of despair. We had everything before us, we had nothing before us. We were all going direct to heaven. We were all going direct the other way. Thank you.